Hello, everyone. Umayma, would you like to start?
Yes. Hi, everyone. Thank you so much for joining us in another episode of Telling Our Stories, Patients Encounter Pearls. For those I haven't met, my name is Umayma. I'm from Morocco, and I'm a CPSC member who's passionate about narrative medicine and clinical reasoning. And I'm joined by my amazing teammate, Laura. Can you introduce yourself?
Yes. Hi, everyone. I'm so excited to be here. My name is Laura. I'm a fifth year medical student from Brazil. And I'm so happy to have you all here today with us on a Sunday. And yeah, that's it.
Thank you, Laura. So on today's Patients Encounter Pearls episode, we are joined by the one and only Dr. Hayley Sharma, aka Multilingual MD, for those who follow her on social media. Dr. Sharma is a second-year internal medicine pediatrics resident at Indiana University School of Medicine. She is originally from Minneapolis, Minnesota, but has lived in Texas, Switzerland, England, and now Indiana. She is a self-proclaimed linguist who speaks English, Spanish, and Portuguese, and is passionate about reducing language barriers in medicine. After residency, she plans on becoming a mid-peace hospitalist in the United States and a humanitarian aid worker in the Brazilian Amazon. Dr. Sharma, thank you so much for joining us here today. Do you mind unmuting and telling us more about yourself and something fun that you did lately?
Yeah, well, first of all, thank you so much for having me. I was saying a little bit before, I just finished emergency medicine overnight shift. So if I say some things wrong, please forgive me. But yes, Mama did a wonderful job with introducing me. I don't really have much to say more than that, but I am really excited to be here and talking about something that's really near and dear to my heart, which is languages in medicine. Kind of my two passions connected into one. But you mentioned something fun. I guess it's not, well, you didn't say fun fact, but I'll give you a fun fact. I'm actually a twin. So I have a twin brother. And he got his PhD in organic chemistry. So I'm glad there's somebody out there that loves organic chemistry. But I would always joke that I got an MD PhD. I got the MD portion and he got the PhD portion. And since we're twins, it counts as one. So that's a little bit about me.
Oh yeah, that's so cool. We have a physician-scientist duo. So yeah, Dr. Sharma will be sharing one of her touching stories. If you're following her on social media, she's a great storyteller, and she'll be sharing one that marked her medical school years and partially contributed to the wonderful clinician that she is becoming. And as she's telling it, please feel free to hop in, put your thoughts and questions in the chat, or if you've lived through a similar experience, feel free to share it. So without further ado, Dr. Sharma, the floor is yours.
Perfect. All right. Okay, so stroke one, the overhead rang at the same time my resident's phone buzzed. Stroke one, emergency department, room 205. We leapt up from our seats and rushed down the stairs to the ED. The staff in the shock room cleared the way as the stroke fellow, the neurology resident, and me, the third-year medical student at the time, entered the room. The patient was a woman in her 70s. Blood pressure 160/90, heart rate 105, respiratory rate 14, 96% on room air. She was frail appearing and lying quite still on the cot. The stroke fellow went to bedside to introduce herself and start the NIH stroke scale grading. The EM physician spoke up. She only speaks Swahili. We've been on hold for the audio interpreter for a while, but her son is right here. He gestured to a man standing just off from the head of the bed. While the fellow worked with the son to evaluate his mom, we heard the story from the ED doctor. The patient had been preparing breakfast for her son when he heard a plate hit the floor in the kitchen. His mom didn't respond to him asking if everything was okay, so he went to see what happened and found her on the floor, unable to talk. He sat her up and then noticed she had a right-sided facial droop and was leaning entirely on her left side. He called a friend to come pick them up to bring her to the hospital. Last known well 1.5 hours ago. No blood thinners, no history of previous strokes or internal bleeding, no major surgeries. Okay, got it. We returned our focus to the room when the radiology tech said that CT was ready for her, and we followed the gurney as she was wheeled away. The son was left in the care of a social worker while we waited for the read. CT, CTA was consistent with a left MCA M2 ischemic stroke. Neurosurgery was paged. The location would be quite difficult to reach with mechanical thrombectomy. TPA it is. Patient was transferred to the ICU for Q1 hour neuro checks, with me assigned to her as part of the neurology team. The next morning, I stopped in her room to check up on her. Her son was dutifully at bedside. How do you say good morning in Somali? I asked him. He looked up in surprise. Subak Wainaksan. Oh, okay, thank you. I then went over to the patient and grabbed her hand. Subak Wainaksan. She stirred, but didn't respond. As the audio interpreter wasn't available at that time, the son helped me ask some questions. She could only squeeze my hand on the left. She didn't even open her eyes. I'll come check on you later, okay? I told the patient. Thank you, I told the son. The next day, I did the same. Subak Wainaksan. I squeezed the patient's hand and then looked over at the son. How do you say my name is in Somali? Maga Aigowe, your name. Okay, so Maga Aigowe Hayley? Yes, exactly. I looked at the clock and realized I was running late for rounds. Sounds good, I'll use that next time. Each morning during pre-rounds, if the sun was there, I would learn a different phrase in Somali in order to connect with my patient on a deeper level. Due to her acute neurological changes, however, I had no idea how much she was actually taking in. Was she hearing me? Was it actually making a difference that I was speaking to her in her own language? I didn't know. Fast forward 2 weeks later, and she had improved significantly on her neuro exam and was ready to discharge to an acute rehab facility. Our team had booked an in-person Somali interpreter to be there for her discharge. As we said goodbye to her, she started crying. Through the interpreter, she said, I don't want to leave because everyone has been so nice to me. She then gestured to me and grabbed my hand. And this one, she is even learning my language. My heart shattered. I could do nothing but hold her hand with both of mine and say, it's because I care about you and wish you the best. That's why I was learning your language. We left the room shortly after, and my heart was warm. So she did hear what I was saying. So my efforts had made a difference. Ever since then, I have made a point to learn phrases in the language of my patients, even if it's just, hi, my name is, thank you, you're welcome, goodbye. The smiles when I greet the patient or the family members in their preferred language after walking in the room, and then the subsequent laughter when I say through the interpreter, sorry, that's all I know for now, will always be worth it for me. It's beautiful that just a few learned words in another language can lead to such a connection and trust from one person to another. It certainly is its own type of medicine, one that is accessible to those who ask and to those who take the time to say, how do you say, I'm here to help in your language? The end.
Oh, Dr. Sharma, I had goosebumps listening to your story, and it just confirmed what I just said. You're a phenomenal storyteller, and I am so happy this patient had you by her side. And thank you for sharing it with us. Laura, do you have any questions or reflections about this topic and Dr. Sharma's story?
Yes, first I want to say that I love this story. It's really heartwarming, and I wonder why like the base, like the base of trust could be like trying to speak the patient's language. Maybe it's because they feel like the patient that is responsible for their care actually cares. Like it's what we should do, but maybe trying to be closer to them by speaking their language is a way of showing them that you care that much. I wonder what do you do differently after that experience? Like what changed for you after that?
I think, something that changed is, so I tend to be one of those people who is either 100 or 0. And so either I'm learning the language or I'm not. But especially after this experience, I realized, it's okay if you can't learn the whole language. Obviously, that's a good goal, but, starting small and learning those phrases, especially the phrases you say every day, like good morning, hello, my name is, thank you, and feel better. Those mean so much to patients. And like you said, it is the connection. I mean, love and connection is made through communication. And a lot of times communication is via your words. And so if you are able to connect to somebody via words that they love, that is their heart's language, that is most powerful.
Yeah, I love your question, Laura, and I do agree with Dr. Sharma. Yes, you can't really rely on those few words that you learn to conduct a thorough history and to direct your patient's care, but they are essential. They create a very special bond with your patients, especially when they are so away from home. And I just want to bring to attention that the people who have these language barriers to care are the same people who are already facing many challenges to get this care in the first place. It's the same people who struggle to take a day off from work to come to their doctor's visit, the people who have a high threshold for seeking care, people who have insurance problems, transportation problems, and added to that, they will have language barriers as well. So how do you think we can make that easier as people who can't probably learn all the languages in the world? Dr. Sharma is lucky in that sense. She speaks 4 languages, but there will always be a patient who speaks a language or dialects we're not familiar with. So how do you think we should best approach these patients and make sure we give them the best care possible?
I love this question because it's a question that we should be asking when we meet someone who has a preferred language different than our own. Some things we can do is recognize that English, or whether in your own country, English, Spanish, Arabic, that it might not be the preferred language of the patient. So I think recognizing that, asking what their preferred language is. So usually I will go into a room and say, what is your preferred language? Do you prefer English or Spanish? Swahili or English? And encouraging them, oh yes, let's get an interpreter then. So I think recognizing, asking, and then, that's at the beginning of your meeting. But let's just say someone says, and this is actually very common because one thing that is also in play here is a power differential between, the physician or the provider and the patient. And so let's say you say, what is your preferred language? And they, say English, and you're talking to them and you're just feeling like something's off. You don't feel like they understand. You feel like there's sort of the nod where you're starting to think, I don't know if they're actually understanding me. It's a great time to take a step back and say, I said a lot of things. Can you tell me what you understand? And that is one way to see, are they really understanding? Is English really something that they is that the language that they prefer, or were they too, modest or too worried about saying that they wanted another language? And so even taking a step back in the middle of the interview and saying, you know what, I think we should, let's reconsider having an interpreter here and being humble enough to change course even in the middle of a conversation.
Yeah, I love this. So yeah, being open and clearly clearly asking your question, your patient, what they are comfortable with in terms of the language they want to communicate in. Laura has some data next about language barriers in care that she's going to share with us.
Yeah, I did a little bit of a research just because I thought the topic was so interesting. And I actually focused on the United States because it is Hayley's country, is where she practiced. So I found some really, I don't know, interesting but sad information about that. So health disparities such as unequal treatment related to language barriers are associated with unequal access to healthcare and unequal health outcomes. And there is a recent study that I'll share with you my references later, but that was conducted in 6 hospitals in the US and found that adverse events occurred more frequently among patients with limited proficiency in English than among those who were proficient in the language. And this is really scary, actually, but there's more. It could lead to incomplete understanding of patient situations and delayed treatment or misdiagnosis, because miscommunication is basically everything when we interact with the patient. And there could be poor patient assessment and incomplete prescribed treatment. And something that I found is that when we interact with someone that doesn't speak our language, we should really focus, like in the moment of discharge, on the medication, like how they should take the medication, and just repeat it like 5 times, just because when they speak our language, it's hard for them to understand. So when they don't, it seems to be even harder. So this is something that I read and I found really interesting information. What do you have to say, Hayley, about this?
Yeah, I agree in that there's a lot of sobering stories and data about this, and especially like you said, medications. That's why the teach back method, if people have heard of that, of you say something and then they say, can you repeat this to me? Or pretend you're telling your husband or your son, or pretend you're telling somebody else about instructions. What would you tell them? To really have them teach back what they saw, and just to assess their understanding. One thing too, I always like to add is, because there's a question of, why is this important? Why is this a thing? And like you said, in the US, there's actually it's a law first of all, to enable people to have access to language assistance. So it was kind of the right to have access to healthcare in their preferred language started in the Civil Rights Act of 1964, which prohibits discrimination on the basis of race, color, and national origin. In those companies and businesses requiring federal financial assistance. And so from that, then the Executive Order 13166, which is called Improving Access to Services for People with Limited English Proficiency, is basically saying, these governmental or federally funded organizations have to figure out how to provide care for people whose English is not their first language. So, this is something that is needed, but it's also something that we have backed by the right for people to have healthcare. So that is also something to be worth mentioned as well.
Yeah, you all of that, or did you just read it? I'm like, does she know this law?
I knew about it, but I will admit that I did read that
Oh,
when I
okay.
was saying it. But I did. You're right. I didn't memorize word for word, but it is something
Yeah,
that
it's amazing.
I say. Yeah, definitely.
I found like a good example of change that I would like to share actually. There was this hospital that had Latin children in their hospital of in the PICU, and they had a 3.7-fold higher risk of mortality than white and African American children. Um, and it would include illness severity, age, sex, insurance status, and diagnosis. And what the hospital did was they implemented a multi-level intervention, including cultural sensitivity training for clinicians, hiring additional bilingual staff, and expanding the availability of trained interpreters in the emergency department and the PICU, and making consent forms and educational materials available in multiple languages. And what happened, it was that 3-year post-intervention period, the PICU mortality for Latin children dropped to a level comparable to the levels of white and African American children. So that was a good example of what can we do? Like, what can the institutions do to help change the situation?
Mhm. I like what you mentioned too about, cultural aspect of it, because that is also something that medical interpreters can help us with, is that cultural aspect of language. And I know there was actually an example of the other day where I just happened to be in the same room as a nurse who is taking a basic history from a Spanish-speaking patient, and so she had an interpreter on the line, and the patient used the word like, se agita, like, and the interpreter was like, well, what does that mean? Like, he was trying to understand exactly what that meant in her specific dialect, and she used it a little bit differently than he was used to, or vice versa. It's also in Spanish, a lot of people will say like, oh yeah, I had like gripe or gripa, and what they're meaning is not necessarily like, oh yeah, like I was diagnosed with the flu, but more like they had the symptoms, they felt like they had the flu. And so having somebody that is able to culturally understand meaning and be able to translate that as well is very, very needed.
Yeah, thank you so much, Dr. Sharma. Thank you, Laura, for your wonderful questions and resources. This brings me to a study that I came across that was done in my continent, Africa. It was done in Ethiopia, and they found that people who are facing language barriers to healthcare they have higher hospital stay. They spend more on the hospital because they can't really ask for itemized bills, or they can't really ask administrators to cut down every cost. And it is associated with a higher risk of error. I'm going to share it here in the chat. And yeah, thank you for what you shared about the laws. I think that having the appropriate laws and the laws really help to make sustainable and meaningful change. Now I have a question for Dr. Sharma. If you have, for example, an advanced level in a language, would you still ask for an interpreter, or would you be comfortable just translate conducting the exam yourself?
Well, that's a great question. So it depends on a couple of things, but one of the things it depends on is actually what your hospital policy is. So for example, to become a certified medical interpreter, you have to take at least in the US, you have to take a national exam. You usually have to have, I believe, at least 40 hours of kind of background training. Again, look, I'm not positive about that, but I think that's the case. And to work at, for example, at one of the hospitals that I work at, the county hospital, providers don't necessarily have to have the national certification, but they do have to pass a test that the hospital puts out for language proficiency. And so if you pass the test, then you are able to interpret in the language that you are advanced or bilingual in. So certain hospitals have kind of regulations regarding what they allow providers who aren't necessarily nationally certified to do. So at least in my case, again, we had to go through an exam. But even then, there are situations where I will actually ask for a Spanish interpreter. So usually if I'm doing 24 or 28-hour calls and it's 3 a.m. and I'm tired, I will ask for an interpreter to help me. Or if it's a situation where it's a lot of medical terminology that I'm just not as familiar, even in English, I will again ask for an interpreter. So I have a very low threshold to ask for an interpreter, and I recommend anybody also have a low threshold, because again, it's putting our pride aside for the benefit of the patient and making sure the patient is at the forefront of everything we do. So that's a little bit of kind of that answer. But one thing I will say, because I have seen this happen, is, especially in the United States, a lot of people will say, oh, I speak a little Spanish, I want to practice my Spanish. And feel free to practice your Spanish in, introducing yourself and, asking some questions, but you really need to have an interpreter there if you are not, at a level where you can have a fully, conversant conversation, understand what they're saying, understand what you're saying. So I've heard a lot of people say, oh, I'm just going to practice, and this isn't the time for practicing. This is somebody's health, and we need to take that seriously.
Yes, I agree 100%. This is not the best time to practice your second or third language. And this reminds me of a story that I witnessed when I was a third-year medical student. We go on medical campaigns in rural areas in Morocco, and in rural areas in Morocco, Arabic is not commonly spoken. And I saw a patient who had chronic kidney disease because she had some arthritis, and the doctors prescribing her the NSAIDs didn't thoroughly explain how she must use them and the precautions to take, or when to seek help, because he didn't speak the language in that village. And now she has CKD. And how do you think, is there a way we can reduce these barriers if we do not speak the language and we're somewhere without access to these interpreter services, or the interpreter is just not available?
That's difficult when like you said, there's not an interpreter there. And so how do you communicate without being able to communicate? I know a lot of times, and these resources are more used in societies where perhaps people have never been taught to read. And so it's a lot of pictorial images that people use in order to talk about medications or diseases. So that is one approach you can take, with a lot of pictures, but it is hard. And I think just acknowledging that it is hard, and you're not going to be able to go in as much depth, then you are going to feel bad about not being able to give the care that you can. So it's hard. If you don't have somebody that's able to speak, and you can try to use pictures and something like that, but it is going to feel bad because you can't communicate how you would want to.
Yeah, so it's practically a battle that you have to lead on two fronts, both the advocacy level and on the floor or at the hospital.
Mm-hmm.
Yeah, go on.
Oh, no, I saw a question in the chat that I really liked.
Yeah, and I want to add something to that question actually, and you can answer both of us at the same time, maybe. I wonder if you have any tips on how to best use the interpreter services, like, and adding to what Abraham said.
Mhm. So, actually, his question perfectly sets up actually to answer that question. So the question was, do you think it's appropriate to depend on a caregiver to translate if the hospital allows it? So my take is no. I do not think it is appropriate to utilize a family member, mostly because there is so much bias that comes with it. And there's a couple of fallacies that you can run into. So the first is, just the question of, are they translating everything that I'm saying exactly how I'm saying it? Are they translating exactly what the person is saying? Medical interpreters are supposed to translate everything you're saying and everything the patient is saying, but with family members, they aren't obliged to do that. And there's been a lot of times where they might answer for the patient, or they may say a question a little bit differently. I actually had an encounter just the other day where this patient was speaking another language, and their family member spoke English, but the patient themselves spoke this other language, and there was an interpreter on the line, and their relative was mostly answering the questions in English. But I asked the patient, oh, are you sexually active? Because that was important for my differential. And the family member immediately answered in English, oh, no, 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 no. And the family member, and then the interpreter interpreted the question to the patient. The patient said, yes. And so, even in those cases, especially when you're talking about those more sensitive subjects, like, sexual practices, your period, like, peeing, pooping, all that kind of more private stuff, family members get kind of awkward, and they either don't want to translate it, or they kind of say maybe an answer that's not correct. And so that's another reason why not to use family members. And I think a third reason is medical terminology is hard. We all have to learn it in medical school, and it's a foreign language to all of us. And I had a friend in college who was a native Spanish speaker, and he's like, I never learned how to say gallbladder in Spanish. Like, I don't know how to say that in Spanish, and so it's a lot to put pressure on for the family member to know these medical terms. And then actually a fourth one, I could go on, but a fourth one is, if you're communicating bad news, now you have put the family member in place. They have to be both the interpreter and the recipient of the news. And so you are now putting them into a couple different roles, and that's really hard for them to hear the news that your mom has cancer, and also to tell their mom you have cancer. And so especially for that bad news, it's unfair to put the family member in those difficult positions. But that's why I love the question, because it's something that happens so often. Because if you're rushed, if you're like, oh, I can't, I don't have time to call the interpreter, or this audio interpreter is taking forever, the person's at bedside, I just want to, I just have a couple of questions. It happens all the time, but definitely really recommend, don't give in to the it's just easier, it's just faster. Do what's best for your patient, and what's best for your patient and the family is getting the medical interpreter.
I love that answer, because you brought some really interesting facts about how the relationship, like the family logistics and relationship that they have, can influence in their answer, and like in your care, if you don't use the interpreter. I actually found an article with tips on how to best use them. I'm going to share here in the chat. And 3 things that I found that could be useful are to maybe access the quality of the medical interpreters by observing how the patient responds to the interpreter, like with the body language or something like that. That could be useful. And try to communicate directly with the patient, even though you have the urge to talk to the interpreter, but then you have to talk to the patient, even though they can't really understand what you're saying, just because they are the main character there. And try to speak in shorter sentences than normal, just because it facilitates for the interpreter to translate. And there are more tips in the article that I shared, and I think it's really interesting to have all of that, and what Hayley just shared about not using the family or the caregivers as the interpreters.
Yes, I love what you said about, don't refer to the patient in the third person. So don't say, to the interpreter, hey, can you ask her how her pain is? No, you are talking to the patient. The interpreter is interpreting your words. And so please, look at the patient and say, are you having pain? Yes, it might feel awkward when you start, because obviously the patient's going to be looking at you with maybe a kind of a blank expression of, I have no idea what you just said. And then the interpreter is going to interpret. But that is a pet peeve of mine, and something it's really important to do is make sure to address the patient directly. And same what you said about short sentences. I usually have as a rule, I say a sentence at a time, and then let the interpreter interpret that sentence, and then I move on. And that helps make sure that your entire what you want to say gets across, because if you kind of say a paragraph, it is really hard to interpret. And so sentence by sentence, it makes it really helpful for the interpreter. One other thing that I would say is something I do for medical interpreters is, before we even go in the room, I give them a little kind of synopsis of what we're going to be talking about. So I'll say, hey, my name's Dr. Sharma. I'm going to go into this room for this 6-year-old male who has a fever and a cough. I'm going to be talking to his parents about what symptoms he's feeling. That way it'll prepare the interpreter for, the conversation, give them a little idea of what they're walking into, because that is completely different than, hey, it's Dr. Sharma. We're going to go into this 80-year-old woman's room. Her whole family's there, and we're going to be talking about hospice. That is just such a different conversation, and it just prepares the interpreter for not only the vocab that they'll probably be using, but also just the tone of voice that they should know to expect that is going to happen in the conversation.
Yeah, thank you so much, Dr. Sharma. These tips are very, very helpful. So just to summarize it, we should give a one-liner to the interpreter to know what they're walking into. Keep it short, talk to them and ask questions in short sentences instead of long ones. And don't talk to the patient in the third person, and also pay attention to nonverbal cues like their body language and their facial expressions. Thank you so much. We have a question from Laura here about how to talk to patients if we don't have easy access to the interpreter. And especially that we're in Sao Paulo, they have a lot of refugees from other countries. So would you do anything differently if a patient is, for example, a refugee, or and you don't have that easy of an access to interpreter services?
Mm-hmm. So that is obviously limited if you don't have an interpreter. I've seen a lot of people resort to apps such as Google Translate. Those obviously aren't perfect, but if it's between Google Translate and nothing, then you have to use something. I know there's a couple of other apps, and I don't know if I'm allowed to say the apps if that's like advertising or something, but there's one app that am I allowed to say apps? Is that fine? I don't know why not.
Yeah, I think so.
Okay. Okay. I think it's an app that I found recently. It's called, and I think this is the one. Yeah, it's called Say Hi, SAYHI. And it's an app that you can like record. The person can speak into it, and then it can translate into whatever language you want. And then you can vice versa. You can speak into it and it'll translate into the language that you choose. And I tried it out in English and Spanish, and I've actually been pretty impressed with how it does. I think it's better than Google Translate. So definitely something that I would check out. Again, I don't get paid anything. I just found it online, but something to check out and see if it works for your language. But I think we just have to resort to apps, and thank goodness for apps that we have them. But it is a hard thing. But I think Laura too is, advocate for interpreters. Like my guess is in the public system, there's probably not a lot of money to spend on interpreters. So that'll be a uphill battle, but advocating for interpreters, advocating for the patients, if QI projects. But I think, at the end of the day, you have to rely on apps to help you.
Yeah, I love this. I just want to bring something to attention, even like between the medical terminology and like conversational English that you talk to the patient, you need some translation in that. Not all patients will understand what's an appendectomy or what like a fancy medical term is unless you explain it. And this is something that we're not very aware of. We just throw in the technical word and assume the patient understands it. And is this something that you typically face, Dr. Sharma? And how do you like try to minimize it in your patients' encounters?
This is another topic that I love, is talking about reducing jargon in medical settings. So yes, this is something that as you kind of continue up the ladder of your medical training, you realize less and less what is a medical term and what's not a medical term. I remember I felt so bad. I was asking a patient, oh, do you have palpitations? And he said, what is that? And I felt so bad because I talked so much about reducing jargon, and here I was talking jargon, and I forgot that palpitations was a medical term. And yeah, so definitely is something that you need to keep in mind. At least in the United States, they tell us that most of our patients to assume that they are at a 6th grade reading level. And so to speak at a 6th grade level, if not a 4th grade level. So like 3-syllable words is something that you want to try to avoid if you can. Or something you can do is you can say the medical term. So, you can say appendectomy, and then you can say what that means is there's something in your body called an appendix, and your appendix, and it's helpful if you have a little picture of what it is, and your appendix is right here, and it can get really like irritated and infected, and it's important to take it out so that the infection doesn't spread to the rest of your body. And that's called an appendectomy. And so you can say the medical term, but then describe it. So then when they hear appendectomy, they're like, oh yeah, I think I heard about that. Like, I think I had an appendectomy. But they know the underlying reason or the underlying meaning. But definitely really scaling back, slowing down, understanding what is jargon and what not. And remember, I mean, most of our patients don't know that they have 2 kidneys in their body. They don't know where their kidneys are. They don't know, we had to learn so much, and we forget how much we had to learn. And so to remember that and then bring it to your patients, and make sure to speak to their level of knowledge.
Yeah, thank you so much. That was very powerful. And this brings us to the last section of today's session, and it's communicating with nonverbal patients. Your Somali patient had like declining neurological status, and she was not like accurately verbalizing. So what are your tips for communicating with sedated patients or patients who are not able to verbalize?
So I loved the term, or I loved what somebody told me, in that, there is no such thing as a, non-communicative patient, because we communicate in so many different ways, by speaking, but also with our facial expressions, with our actions. And so I'll kind of take this kind of two parts, because I feel like sometimes, nonverbal is different than sedated a bit. And mostly I just say, because in the pediatric world, I work with a lot of patients who are autistic, and are nonverbal, or have other developmental disabilities and are nonverbal. So with them, it's a lot of reading body language. But even with that, it's even asking their caregivers, how do they communicate? How do they show love? How do they show anger? How can I communicate with them? And so I actually, before medical school, I worked as a certified nursing assistant, and I took care of several different patients who had severe physical, mental disabilities. And one of them I, communicated by like tugging your hand and gripping it really, really strong. And that meant that he was really, really happy. Another person was really happy when they screamed. And so communicating like, oh, no, they're not upset, they're not hurting, they're happy. And so that having somebody help you understand how they express their emotions is really helpful. Definitely use your parents, definitely use your caregivers in these situations, and be open to different modes of communication as well. Same with nonverbal, it doesn't necessarily mean that they can't hear and understand. So still give them the knowledge, but recognize that the way they communicate with you might be a little different. With sedated patients, this is also something that I am passionate about. So whenever I work in the ICU, I always make a point to, you go in the room, and I don't care if if the propofol is like super high and their RAS score, if they are super sedated, I'm still going to go in and say, grab their hand and say, hi, I'm Dr. Sharma. I'm the doctor taking care of you today. It's nice to meet you. I'll usually say things like, you're in the hospital, you're safe, your family knows you're here, we're taking good care of you, okay? And just kind of reassure them as well. So, and then I'll talk through my exam. So I'll say, hey, I'm going to listen to your heart now. I'm gonna look at your wound, and just talking through everything that you're doing, because I believe they can hear you, and they are more aware than we think. And so making sure to communicate with them, and just as you would somebody who is awake.
Yeah, I love this. And when we looked into this, Laura and I, we couldn't really find any data showing that they can hear us, but at the same time, there is no data showing the opposite. So better not take any chances. And this reminds me of my 6th year in medical school. I was in the neurological ICU, and there was this patient who no one thought would like wake up again. And whenever I come in, I would introduce myself to and tell them what I'm about to do, especially when I'm like drawing blood for an ABG. And like after 2 weeks, he woke up eventually, and he remembered his wife being at his bedside. He remembered what she was telling him. So I don't know what else he was able to hear, and I'm glad I took this few seconds to let him know that he's seen, that like we're looking at him, not through him. And this is something that I will plan to implement throughout my clinical years. Um, like the other thing I wanted to talk about is like what we can learn from the pediatrics world. I know most of us here are going into adult medicine or some subspecialty in adult medicine, but there's so much to reflect on and to learn from pediatrics. So thank you so much for bringing your other hat to this today, Dr. Sharma. Laura has some additional data backing up what we just said. Laura, go ahead.
More data. But it's just because it's so interesting, and I found like really interesting facts that I would love to share. So I found this article that talked about like the results for the patient of being unable to communicate and interact. And it could result in psychological alterations as well as isolation and reduction of self-esteem. And something that like was the most meaningful information for me is that patient clinician interactions usually focus on items perceived as relevant by clinicians, but not so much by the patients. And I found that up to 50% of ICU patients could potentially be served by a variety of available tools to enhance communication, but most people don't use them for time constraints, for lack of tool availability, or insufficient training. And I found that there are two types of technology to speak with patients that can speak. So low technology and high technology. You could basically give them a paper and a pen and ask them to draw or write whatever they can, if they're able to use their hands. But there are also like boards that you could use, and even like touch screens and infrared eye blink detectors. So like these ones are more expensive ways to communicate with them. But there are tools that we could use, but most people just don't. And the fact that they have things that they perceive as important, and we don't approach or address those questions that they may have, this is really meaningful for the quality of care that we are providing. So
yeah, I really like the kind of like you said, how can we utilize other means to communicate, to help them communicate, you know, whether it's, I know most common that I see is the pen and paper, but I know in the world of people with disabilities, there is a lot of like it is cool. I saw like your eyesight can look at words, and that's very cool. And how do we bring kind of those adaptable devices into the places where people cannot communicate via words? Something too, I also wanted to mention, just because this is something that I think is really fun whenever I go into the ICU, and sometimes the ICU nurses get a little annoyed at me, is I love asking families about what their loved one's favorite music is. And then whenever I go pre-round, I'll go on YouTube and play their music, and then I'll leave the room and still have the music on. So like I had a patient, a peds patient, who like loved Justin Bieber, but like the old Justin Bieber. And so I would go in the room and I would turn on like Baby by Justin Bieber, and I would like blast it in the room with the patients, and like the patient was smiling, you know, like they clearly loved it. But so like anytime I have a patient who is sedated, cannot communicate, I will always ask the family what is their favorite music, and then I will make sure that it is playing in the room, because if I were in their position, I would love, people playing some like reggaeton or like some like sertanejo, or like all this like good music that would make me feel relaxed. So that's also kind of a way to show love to your patients is by music.
I love this. I love your question, Laura, and I love Dr. Sharma's reflections. Thank you so much for this session. It was very humanizing. Medicine can be tough, and it's very important to have this kind of spaces to reflect on difficult encounters or encounters that marked us and we want others to learn from. And sometimes it's helpful to put the shield we put to protect our mental health, to pull it back like just for a second and humanize our patients. And these are very small things, like saying hi in your patient's native language, putting on their favorite music, but they make a lot of difference. So yeah, thank you so much, Dr. Sharma, for these tips, for this humanizing session, and for the tips, and for the invitation to check our own biases and the things that we are probably doing wrong. And I'm sure we will all leave this session better doctors and better humans. Thank you so much, Dr. Sharma. Dr. Laura, do you have any final words?
Dr. Laura, not yet, just Laura. Yeah, I want to thank everyone for being here. I had a great time with you. Thank you, Hayley. It was amazing to learn from your experience and your reflections. You are a really inspiring person and professional. And thank you, Umayma, for being my partner. And thank you, everyone, for just hanging out with us. It was amazing.
Thank you, everyone. Feel free to message me any questions you have. Obviously, I love talking about this, so would love to interact all with you. And thank you for CP Solvers for letting me talk about something as important as language barriers to care. So really appreciate it. Thanks, guys.
Our pleasure. Thank you, everyone. Enjoy your Sunday.